Today we're going to talk about joint mobilization and manipulation. The objectives are to discuss the historical and current concepts of mobilization manipulation, define terminology of joint mobilization, summarize the basic concepts of joint motion, identify indications and goals, as well as limitations, contraindications, and precautions for joint mobilization. We're also going to describe the procedure for applying joint mobilization. Before we go any further, let's define the term orthopedic manual physical therapy. Joint mobilizations are going to fall under this category umbrella of physical therapy interventions. According to the description of advanced practice published by the American Academy of Orthopedic Manual Physical Therapists in 2007, OMPT includes any hands-on treatment provided by the physical therapist. So this can include joint mobilization, manipulation, stretching, passive movement, soft tissue techniques, and manual resistance. The definition of mobilization manipulation, according to the American Academy of Orthopedic Manual Physical Therapists, the APTA, and IFOMT, the international accrediting body for manual physical therapy, define this as a manual therapy technique comprised of a continuum of skilled passive movements to joints or related soft tissues that are applied at varying speeds and amplitudes. This includes a small amplitude, high velocity therapeutic movement, which is also known as a joint manipulation technique. Manipulation has been used as an intervention for a long time, and documentation would support that at least it's been since 2000 BC. In the late 1800s, manipulative therapy was claimed by both osteopath and chiropractic schools of thought. PTs have been manipulating since the 1820s in Sweden, and it was further refined in Norway and Australia. Here is an example of a setup of a manipulative technique. Let's watch a few videos that are examples of manipulative techniques.
Identify the lateral aspect of the articular pillar of C4 on the right. Apply your applicator to the contact point. Take up the cradle hold and adjust your balance. Primary leverage side bending right, secondary leverage rotation left. The thrust is down towards the couch and towards the patient's left shoulder.
So what you can see as illustrated by this video is that it is a high velocity but small amplitude movement. So it's not as aggressive as some people would typically picture a manipulative technique to be. Let's look at another example of a grade 5 manipulative technique to the lumbar spine.
Position the lower leg so that it is in a straight line with the spine. Identify the L3-4 segment. Add upper body rotation to the right, maintaining the neutral position. Take up the auxiliary hold and rotate down to L3. Now add pelvic rotation up to L4. Final minor adjustments. Rotate the whole body towards you and thrust down to the couch and towards you.
The success in many of these techniques that you're seeing in the video are really based on a proper setup, but also proper positioning of the therapist. This particular example is an example of the lumbar spine lumbopelvic technique. So you can see the therapist is very diligent about the setup. And you can also see how his body mechanics are really such that it's giving him a position of maximal leverage. But please also recognize and appreciate that, again, these are small amplitude movements. So what are some of the basic concepts of mobilization and manipulation? It's used to increase joint and soft tissue mobility, and loss of mobility, as we discussed in the summer and the fall, can be due to pain or stiffness. So mobilization manipulation might be indicated to reduce joint hypomobility, delay some stiffness from disuse, address pain, or also to maintain joint mobility when full active range of motion is not available. Another concept that was discussed at length in the fall in movement science was osteokinematic and arthrokinematic movement. As a review, osteokinematic movement is movement of the bones during normal movement. It's the physiological movement, and it's typically performed via active muscle contraction. So rehabilitation or intervention directed at osteokinematics is typically achieved through range of motion and stretching. And this is primarily aimed at the contractile tissue. So in Foundations of Intervention 2, we got used to using this as an intervention through passive range of motion, active assistive range of motion, and also muscle lengthening techniques. Arthrokinematics is movement of the joint surface. It's also called accessory movement, and it must occur for normal physiological movement to occur. Mobilization manipulation restores the arthrokinematics of the joint, thus improving the osteokinematics. Treatment has to be based on proper examination. So just as you demonstrated this fall, at some point in our examination, we're going to be looking at observation. And again, observation through either posture, whether it's static standing or sitting, observational movement analysis, task analysis, or performance-based outcome measures are really going to start to drive our hypothesis and determine what subsequent tests and measures need to be done in order to determine what proper treatments are going to be needed for this particular patient. In the musculoskeletal conditions track, you're going to be introduced to a framework called the 6x5, which will help you move through the examination in a very thoughtful way. However, movement is still going to be at the forefront of this examination. And based on what you see with movement, this will help you determine what active range of motion you need to look at, passive range of motion, which includes end feel, and also what resisted testing you need to do. Resistance testing is really gross testing of the contractile tissue. And based on the results you get here, it may help you determine which manual muscle tests need to be done, which length tests need to be done, and potentially which tissues need to be palpated based on irritability. But the last bullet here is describing a skill you have not learned, which is accessory motion testing. Decreased accessory motion is the primary indication for joint mobilization or manipulation. Accessory motion testing has to occur before you put joint mobilization or manipulation in your plan of care and design interventions for accessory motion. If we're talking about specific joint motion, active, passive, and resisted movements are all used to assess the status of the tissue around the joint. Active range of motion, as you remember, tests the general willingness and ability of the person to move. It really assesses the contractile tissues. Whereas passive movement tests the movement that's available, and we also get information from the end feel of the joint. We're also going to elicit information about pain and particularly movement. So if the passive range of motion is full, but the active range of motion is not, we may hypothesize that we need to do manual muscle testing of that particular muscle in order to determine what the impairment might be. Resisted testing tests the status of the musculotendinous tissue. And again, it's really going to help us to determine whether we need to move on to manual muscle testing, whether we need to palpate tissue, determine length. But it's going to give us information about tears, inflammation, and really what's happening at the level of the muscle or the tendon. Another way to assess specific joint function is through traction and compression, and this moves the joint apart or together. And that gives us information about what's happening at the level of the joint. Accessory motion is where we are actually moving the joint surfaces. So if we talk about passive joint mobility testing, again, we're talking about osteokinematics through passive range of movement. We're talking about arthrokinematics through passive accessory movement. And when we're looking at passive joint mobility, typically one of three conclusions can be drawn. The joint is either deemed to be normal, it's deemed to have excessive movement, which we call hypermobile, or it's deemed to be reduced and have reduced movement, which we call hypomobile. And it's important to always compare bilaterally. So if we're using accessory motion as a test and measure, it's important to make sure that we check bilaterally because each person is different and each joint is different. We also want to take into account and monitor for any symptom reproduction that may happen. So if we're talking about accessory motion testing, what we're doing is we're creating small passive movements that are necessary for painless volitional movement. And again, when we're talking about arthrokinematics, we're moving the surfaces of the joint. So based on our observation of movement or our active and passive range of motion, if we evaluate the joint and we hypothesize that there's hypomobility or hypermobility, this would drive us to using accessory motion as a test and measure. As you can see in these different pictures, these are different methods of producing accessory motion at the shoulder joint or the glenohumeral joint. In picture A, the therapist is producing an anterior to posterior accessory movement. In picture B, they're producing a posterior to anterior movement. In picture C, they're producing a distraction at the glenohumeral joint, followed by D, which is a long axis distraction or inferior glide at the joint. All of these glides are going to give us information about what accessory movements may be contributing to limitations in osteokinematic movement. For example, this summer we looked at the radiocarpal joint, and we decided that the radiocarpal joint is synovial and has 2 degrees of freedom, those being flexion extension, radial deviation, and ulnar deviation. We also talked about the concave and convex rule in this joint. The proximal surface of the proximal row is going to act as our convexity, and the convex proximal row is going to move on the biconcave distal radius and articular disc. So with the movement of flexion and extension, the proximal row will roll and it will glide in opposite directions. If we're talking about the movement of radial and ulnar deviation, which again is the osteokinematic movement, the proximal carpal row is going to roll and glide in the opposite direction. And again, that's because we have a convexity that's presenting on a concavity. We practiced this summer. One of the accessory movements that we practiced was distraction of the radiocarpal joint. And then if we're talking about the movements of radial and ulnar deviation, the other accessory movements or arthrokinematic movements that we practiced were a lateral glide and a medial glide, matching with the movements of radial and ulnar deviation. One concept to be aware of is the concept of pattern of motion restriction. So Cyriax introduced the concept of capsular and non-capsular patterns of restriction. A capsular pattern, by definition, is limitation of pain and movement in a specific joint ratio. Sometimes this is indicative of an arthritis. A non-capsular pattern is limitation in a joint in any pattern other than a capsular one. So the derangement or the impairment may just be on one side of the capsule in one particular direction, versus a capsular pattern, which may show that there's limitations in multiple directions within that joint. Examples of capsular patterns of restriction include the glenohumeral joint. In this particular example, lateral rotation is more limited than abduction, which is more limited than medial rotation. At the hip, flexion is more limited than medial rotation or internal rotation, which is more limited than abduction, and so on. We also talked about the concept of end feels. We have normal end feels and abnormal end feels, and we practiced this throughout the summer and the fall when we were talking about passive range of movement. So one of our goals was to familiarize you with the different types of end feels that we should have at particular joints. We also talked about the concept of an abnormal end feel, but when it comes to intervention, the only abnormal end feels that we really treated were soft or boggy due to edema, and in that situation we may have done interventions such as electrical stimulation, soft tissue mobilization, or just very gentle passive range of movement. We also talked about elastic, firm, muscular end feels. The intervention that we used to treat muscle end feels that were earlier in the range were typically the intervention of muscle lengthening. If we had an end feel that was muscle spasm, we often talked about electrotherapeutic modalities that could be used to treat this. An empty end feel as an abnormal end feel typically means that the individual is limited by pain. The end feel that we did talk about was the capsular end feel, and we decided that when the capsular end feel was happening earlier in the range than we expected, it was considered abnormal. We didn't talk about how to treat this, but that's what we're going to be treating now through our joint mobilization and manipulation techniques. So it's helpful for you to continue to try to recall what the normal end feels are in each of the joints that you're going to learn to examine. That way, if you end up with an end feel that is not what you're expecting, you might explore this joint further and determine what impairments might be causing this abnormal end feel. Let's talk about passive versus active range of motion. According to Cyriax, if active and passive motions are limited and painful in the same direction, the lesion is in the inert or non-contractile tissue. This is an example of an impairment in the joint. So if we have active that equals passive and they're both limited in the same direction, we can use the example of shoulder flexion. If the limitation is 120 degrees as opposed to our normal 180 degrees, and we get an early abnormal capsule end feel, this typically leads us to believe that the lesion is in the non-contractile or capsular tissue. If we have the example of active and passive movements that are limited and painful in opposite directions, the lesion is typically going to be in the contractile tissue. This would lead us to believe that there might be issues with muscle strength and muscle length as being the issue. So if we go back to talking about mobilization and manipulation as an intervention, what are some of the effects that we can expect? Listed here are a number of the effects that are documented in the literature. We can expect increased extensibility of both articular and soft tissue. Sometimes we can expect breaking of adhesions, which might actually be the therapeutic goal, stretching the capsule, correcting positional faults, although sometimes this terminology is a little bit more specific to the chiropractic and osteopathic schools. We can promote movement of synovial fluid just by the fact that we're in the joint creating movement. There's sensory input that's occurring via mechanoreceptors that can actually help to modulate pain and muscle tone. We can expect sometimes to improve function by addressing impairment such as pain, decreased range of motion, and faulty movement. And then we're also going to see a number of other mechanisms that are going to occur. But there is a lot that is occurring as a result of joint mobilization and manipulation that we can't quite describe. There are a number of neurophysiological effects that are occurring at the level of the peripheral nervous system, the spinal cord, and also supraspinal mechanisms. If we look at this schematic by Bialowski and colleagues, this really helps to illustrate some of the mechanisms that are at play when we're treating musculoskeletal pain. The mechanical stimulus is elicited here, and then a whole plethora of responses are going to occur. Decreased spasm, increased range of motion, release of inflammatory mediators. We're also going to see hypoalgesia as a side effect, as well as neuromuscular responses. We're going to have endocrine responses, which is going to include release of beta endorphins and more or less an opioid response. There's going to be some autonomic responses and other nonspecific responses, such as placebo, expectation. So just keep in mind that even though the goal might be to improve motion, realize that there are a number of other mechanisms that are at play when you are providing these interventions. Let's talk about some of the contraindications and precautions that we need to keep in mind. Contraindications may include other health conditions such as rheumatoid arthritis and genetic disorders. Some genetic disorders predispose individuals to having laxity in certain joints. Acute infection or inflammation, acute circulatory conditions or compromise of the vertebrobasilar system or the vertebral artery, bone disease such as osteomyelitis, osteoporosis, even osteopenia, and other diseases that impact bone. We also want to be aware of things such as cancer and cellulitis. Other precautions include unhealed fracture, excessive pain or irritability, hypermobility, total joint replacements, pregnancy, spondylolisthesis, muscle guarding, and anticoagulation therapy. Again, these are precautions, and every situation is going to be different. There are times where we may provide these interventions for individuals that have some of these because they need the treatment. But again, each individual is going to be different, and we have to take into account some of these other health conditions or issues that may impact this intervention. The types of accessory motions that we're going to be practicing throughout the semester and further include the slide or a glide, the roll, the spin, and compression or distraction. Many of these terms are familiar to you through movement science, which you completed this fall. By definition, a roll is a series of points on one surface are going to contact a series of points on another surface. By definition, a glide or a slide is going to include a single point on one surface, contacting a series of points on another surface. A spin is going to be a single point on one surface rotating about a point on another, similar to a spinning top. So these joint surface relationships are going to be really important moving forward. You're going to want to be able to recognize and name what some of these joint surface relationships are. Another thing to consider when talking about joint surface relationships is the concept of closed-packed and open-packed positioning. Closed-packed positioning is a concave surface in complete contact with a convex surface. So we're talking about maximal bony congruency. Primary stabilizers tend to be on tension, and this is considered an unfavorable position for joint mobilization. An example of a closed-packed position is going to be full knee extension. This is where you have maximal engagement of the concave meniscus with the femur. So again, maximal bony congruency, which is not going to naturally allow for a lot of movement. Conversely, the loose pack position or the open pack position is going to be the resting position of the joint. In this situation, we're going to have minimal bony congruency and the most available motion. Primary stabilizers are typically going to be on slack, and this might be the best position to begin the evaluation of joint play, otherwise known as accessory motion or arthrokinematic motion, and for testing the restriction to the motion. It's also going to be the most tolerable and typically the most favorable position to start joint mobilization. The example with the knee again of the loose pack or open pack position is approximately 30 to 50 degrees of knee flexion. If we're talking about the concave-convex relationship again, realize that we can take advantage of this relationship when we are using joint mobilization and manipulation as an intervention. Again, when the concave surface is moving on the convex surface, the roll and the glide are typically going to be in the same direction. A concave surface moving on a convex surface might be an example of the ulna moving on the humerus. When the convex surface moves on the stationary concave surface, the roll and the glide are going to be in an opposite direction. An example of this might be the glenohumeral joint. So we have the humerus, which is presenting as the convexity, moving on a concave glenoid. So if we're talking about the osteokinematic movement of shoulder flexion, we are actually getting a roll towards flexion, so that's the osteokinematic movement, but the glide is going to be inferior. So the roll and the glide are going to be in opposite directions. Let's talk about some specific mobilization techniques. If we're talking about mobilization, in the neck region, there's an illustration here of us performing a passive oscillatory movement of varying amplitude applied within the available joint range of motion. This is often described as a small amplitude movement or oscillation at end range, and we're going to dose this typically 3 to 4 bouts of 30 to 90 seconds. That's typically how we're going to see the dosing described in the literature. After we perform 3 to 4 bouts of 30 to 90 seconds, it would then make sense for us to do some kind of a reassessment to determine whether or not that intervention has value. We may do a number of reassessments even within one treatment session, or we might do a number of techniques that are specific to a region before doing a reassessment. It really depends on the patient presentation. Let's talk about how we document and describe the intervention of mobilization manipulation. When we're describing this, we often use grades. So let's go through first and define these. Grade 1 is a small amplitude movement at the beginning of the range. A grade 2 is a larger amplitude movement between the beginning and the mid-range of the movement. A grade 3 is a large amplitude movement that is reaching the limit of the range, which in this illustration is called the PL, or the point of limitation. A grade 4 is going to be a small amplitude movement at the end of the available range. Again, moving right up to the point of limitation. A grade 5 is a high velocity thrust movement beyond the range of motion, but not past the anatomical limit or anatomical barrier, which here is illustrated by AL. A mnemonic that we often use to remember the grades are baby, big, big, baby. What that means is at the beginning, a grade 1 is going to be a baby movement, so a small oscillatory movement. A grade 2 is going to be big, so this is a larger amplitude movement. A grade 3 is also going to be big, a large amplitude movement, but now we're moving towards the point of limitation. A grade 4 is going to be a small amplitude movement at the end of the available range. Another illustration to show you this barrier concept. The barrier concept helps us to understand normal versus abnormal movement. And we can see that each joint has a maximal anatomic excursion, and that our functional physiologic movement occurs within that range, with more passive than active motion being available. In the case of a restriction, such as a contracture or an adhesion in the joint capsule, the restrictive barrier is formed, and what we see as therapists is abnormal movement. You should note that just before the restrictive barrier, slight resistance to the motion is perceived by the provider or the physical therapist. Recognition of the restrictive barrier is an important point in being able to gauge the grade of the technique. So looking at this illustration here, adapted from Maitland, you can see the small amplitude, grade 1, which is out of resistance, often used to treat pain. Also, we have our grade 2 movement, which is a larger amplitude movement, still out of resistance, also used to treat pain. Grade 3 is our larger amplitude movement, which is starting to move into resistance. And a grade 4 is a small amplitude movement, which is starting to move into resistance. Grade 3s and 4s are also typically used to treat limitations in movement or motion. Manipulation, then, is going to push beyond the restricted barrier. So if we look at grades of mobilization, grades 1 and 2 are typically used to treat pain prior to reaching resistance. We describe resistance in two ways. R1 is our first perception of resistance, and R2 is going to be closer to the barrier and is our second perception of resistance. Grade 3s and 4s are going to be used to treat resistance or joint restriction when pain is not a factor. So, in summary, grades are intended to convey information to other therapists, such as where the initial resistance occurs, which we call R1, and where the end resistance occurs, R2. We also talk about onset of pain, as described by the patient. Initial onset of pain within that range is going to be called P1, whereas the limit of pain is going to be P2. So for pain relief, if the individual is irritable in that particular joint, we may decide to do grade 1s and 2s before R1 or initial resistance. For stiffness that tends to be non-irritable, we're really going to be producing an intervention that functions between R1 and R2, and it's going to be a larger amplitude movement. Or we may use a grade 4 at the end range at or near R2, and again, this is going to be a small amplitude movement. Grade 5 is typically termed as a manipulation, small amplitude, high velocity. Realize that within one treatment session, if the patient has irritability in that particular joint, we might start with grade 1s and grade 2s. But after we spend time, or after we produce multiple bouts, we may then have some pain relief or decrease irritability which would allow us to move into higher grades, such as grade 3 and above. So you can actually have changes of the grades that you're able to provide as the intervention, even within treatment. However, there are some individuals, maybe someone who recently had a post-operative procedure, where the main reason why you're using the mobilization is for pain relief. So it might make sense just within that first treatment to stay within grade 1 and 2 to help the patient get some of the pain relief that really results from those neurophysiological effects that we described earlier. Here's an example of a grade 4 technique. In this technique, the therapist is taking the glenohumeral joint close to that barrier, or maybe that R2, and producing small oscillatory movements. You can see that he's placing the glenohumeral joint towards the end here in physiological flexion. He's then producing an inferior glide using a grade 4 technique. This is an example of how within one treatment session, the provider may move between multiple positions and multiple grades in order to achieve an ideal treatment effect, which in this case might be an improvement in shoulder flexion. Again, here, an inferior glide, trying to slowly improve the amount of abduction or flexion that occurs. Here's an example of a high velocity technique at the talar crural joint. Okay, again, high velocity but very low amplitude technique. So when we're talking about grades of movement, Kaltenborn describes this as 3 to 4 sustained holds of 30 to 90 seconds. But we may also see this described as more of an oscillatory movement, which is how Maitland would describe these. All of these illustrations are in an effort to help you grasp and understand the grading system that we use. Grading is not used when we're using accessory motion as an examination. When we're talking about examination, we're deeming the joint to be normal, hypomobile, or hypermobile. But typically when we are talking about intervention, in an effort to convey information seamlessly between providers and describe the intervention that was performed, we very typically will use this grading system so individuals, including ourselves, know what interventions were performed and how. When we're selecting techniques, we want to identify the major complaint. Is the complaint pain, or is it stiffness, or is it both? If it's typically pain, we're going to use our lower grades 1 to 2 and stay out of areas of resistance. If we're talking about stiffness, we're going to use some of our higher grades 3 to 4 and beyond in order to really impact the resistance or the end range. If we have a combination of pain and stiffness, we might actually choose to put the individual in a physiological or osteokinematic motion position. This example might be shoulder flexion again. So instead of putting the shoulder in the open pack position and producing our accessory motion, we might choose to put the shoulder in end range flexion and then produce small movements just within that physiological movement. This is very hard to describe through a module, so this is something that you're going to get more practice with in class when we move into the laboratory setting. Again, if we have pain and stiffness as a combination, we might start with grade 1 or 2 movements and then progress to higher grades as described before as the patient improves in their tolerance and decreases in their irritability. When we're preparing to perform joint mobilization, the clinician really needs to ensure proper setup from the very beginning, starting with good positioning that allows the patient to be relaxed and for the therapist to have good mechanics. Remember back to how we helped you with your body positioning when we were performing passive range of movement. It's very similar to that. The better positioned the individual is and the more supported they feel, the more they're going to be able to relax to allow you to perform your accessory motion intervention. But prior to getting to this point, we want to make sure that we have a solid pre-assessment. We want to make sure that we've already gone through all of our examination items, including all tests and measures that would help us lead to joint mobilization or accessory motion as being an ideal intervention. If we're trying to reduce pain, we initially want to address accessory motions in the open pack position, starting with grades 1 and 2. This helps the patient to warm up to the idea of what we're doing, but also gives us a sense of the tissues and the available movement. Then we may be able to progress to either physiological movements or to higher grades in that open pack position. If we want to decrease joint stiffness, we might initially go to the physiological movement and work at that end range, and then we can layer on other accessory motions in that physiological movement. We can repeat this multiple times. If the patient does increase in their irritability, then we might just back down our grades and start using lower grades, such as a grade 1 or a grade 2. Again, really grasping and understanding how we move between positions, grades, physiological movement versus accessory motion, or accessory motion layered onto physiological movement, really needs to be practiced in the laboratory setting. If we're talking about direction of movement, one of the other procedural factors that's really important is to have the hands as close to the joint as possible. In general, one hand is going to stabilize where the other hand is going to mobilize. And typically we're trying to target a treatment plane. So when our head, we're trying to picture, do we want to stay parallel or perpendicular to the concave joint surface, for example? If we're doing a glide, then we want to move the joint parallel to the joint surface. Here's an example of the glenohumeral joint. So if, again, the goal is to glide, then we want to keep these surfaces parallel. If the goal is to traction the joint and move it perpendicular to the joint surface, then again, we want to keep in mind where the joint surfaces are, and we're then going to be moving the glenohumeral joint with a traction force. When we're talking about preparing to perform joint mobilizations, the patient needs to be relaxed. We also want to explain the purpose of the treatment and the sensations that the patient is going to expect. Before we get to this point, though, once again, we want to make sure that the pre-assessment has already been determined. This is valuable both for the clinician and for the patient. Because if the intervention does not have value and there's no change in the assessment, then we may want to move on to another technique, potentially in another direction. Typically, when we're providing any intervention that involves joint mobilization, we will begin with gentle oscillatory movements, grade 1, in order to warm up the tissue and determine what the motion is like. This also helps the patient to relax. Again, assess before, during, and after treatment. Stop the treatment if it's too painful for the patient and consider moving to a different intervention, or maybe just a different mobilization in a different direction. And always make sure that you take the time to position the patient, drape them properly, and make sure that you're using proper body mechanics in order to effectively provide these interventions. Remember, we're doing 3 to 4 bouts of 30 to 90 seconds. And sometimes we might repeat that in another direction. And so you may be spending long periods of time in a single position while you're providing these interventions. Assessment and reassessment can't be stressed enough. We often refer to this as the asterisk sign. So this is the comparable sign. It allows the clinician to really assess the effectiveness of the treatment, both immediately within session and over time. It also is going to serve to guide the intensity of the future treatment and helps us to determine how we might progress this in subsequent treatments. Personally, I use the asterisk sign to help the patient understand and see the value in some of the interventions that I'm performing. We also want to make sure we're documenting what we do. When we're documenting, we're going to document the rate of the force, the location in the range, the direction of the force, the target, the relative structural movement, and the patient position. Here again is an example of a setup of a particular patient. And if we're going to talk about examples of how we would document some of these, we might describe a lumbar technique as a high velocity end range, right rotation force to the lower lumbar spine, on the upper lumbar spine, in a right side lying, left lower thoracic lumbar side bent position. If we go back to this particular example, we might be describing this as a high velocity end range force of the upper thoracic spine on the lower thoracic spine in a supine position. Thank you for listening to the Joint Mobilization Manipulation module. We expect that you will have multiple questions and hopefully recall on some of this information as you move into the laboratory component of this course. Thank you.